adulthood, continuity tends to increase. In other words, adherence to a single family physician tends to increase. We see that same pattern, but at a higher level, for our teenagers, those diagnosed age 15 to 19, so who were 5-year survivors at adulthood or age 20. So overall, they saw a single family physician more often than their peers, and they increased that adherence, that continuity over time. For all the children diagnosed under the age of 15, the pattern was completely different. Less adherence to the same family physician as time goes by. So that's very worrisome, because what it meant was that a current family physician would not necessarily know any of the medical history or any of the medical risks faced by these individuals in adulthood. Another question we asked ourselves was, well, can we stratify our groups of survivors based on their level of risk in order to target the model of care to the level of risk and follow-up they need. So we looked at identification of risk groups based on our data on what risks different subgroups had, and then did some research on what models of care have been proposed for these survivors to try to connect the two. We also looked at system costs and capacity and ability to meet demand as part of this later work. So although there's general recognition, and you saw that in an earlier slide on